have the honor of introducing our distinguished seminar speaker, Pinar Keskinocak. She is the William George Chair and Professor in the School of Industrial Systems Engineering at Georgia Tech. She's also the Director of the Center for Health and Humanitarian Systems, and she's the Associate Dean for Faculty, which is a challenge at Georgia Tech, I can promise. She has won numerous awards and honors. As an example, she's a Fellow of Informs. She's also an advanced professor. In addition to being sort of a preeminent scholar at Georgia Tech, she has a real interest in diversity and inclusion, and she's done some real meaningful change with regard to both the search process and promotion and tenure that was instituted not only at the school level, but through the whole university. I should say on a personal note, I had the pleasure of working with her for many years, and I can honestly say I learned more from her in our interactions than from anybody else in my academic career, and I'm really grateful for that. And I get asked still about what I miss most about Atlanta, and there's a lot of things. I certainly miss the restaurants in Buford Highway, the spring that's about to happen with sort of the flowering dogwoods, Pingy knows. But the thing I miss most is that Pinar lives in Atlanta, and I don't get to work with her anymore. And so I'm really glad that she accepted Andrew's invitation to come out of her busy schedule and give us a seminar. She's going to talk about, she works with many different organizations, Centers for Disease Control, Grady Hospital, Emory, and she's going to talk about some issues that she's worked, a few topics that she's worked on. I think one of the things that's really unique about her research is she doesn't stop with the publication in management science or operations research. She's really interested in the full implementation. I think you'll get to see a taste of that in her talk today. So please join me in welcoming our speaker, Pinar.
Thank you. Well, thank you so much, Paul, for the wonderful, heartwarming introduction, and thank you all for having me here. It's truly a pleasure to visit campus, to meet old friends, former students, colleagues that I've known from before, as well as meeting new folks and hearing about all the wonderful, exciting work that you are doing. And I understand this is very typical weather for this time of year here at Purdue, so I'm happy to come on such a beautiful day and visit you. So what I'll do today is to focus on some of our recent work that is more on the applied side, in terms of taking our research and applying it in practice. Some of the work I'll present has already been fully implemented. Some of it is still in progress, on its way to hopefully being implemented and impactful. So you'll see a range. But before I begin, this is my 20 seconds of shameless advertising about our Center for Health and Humanitarian Systems. We have activities along different dimensions, including education, outreach, as well as research, of course. So I hope you visit our website, and would love to hear from you if you are interested in some of these areas and would like to talk. Okay, so here is our outline today, and I am not going to cover all of these in detail. I could go as faster or as slow as you like, and I would like this to be interactive. So please feel free to interrupt me, ask questions at any point in time. If we reach the end of our hour, I believe I have about an hour, I can summarize either one of these in 1 or 2 minutes, the elevator speech. So, like I said, so please do not hesitate to interrupt me as we move forward. So I'm going to start first with catch-up scheduling for vaccinations. This is a decision support tool that's helping us make decisions at the individual level. The second one is also similar in flavor, that trying to help physicians and patients make some decisions at the individual level, in particular considering trade-offs between different decisions and how to evaluate these trade-offs in a quantitative way. The third one is similar in nature to the second one. Again, you may be facing choices between, based on a test result, doing a potentially invasive diagnostic test versus not, and how do you evaluate these trade-offs given your personal choices as well as your personal physical characteristics. Number 4 is in a facility or organization setting. So it's more a typical industrial engineering problem where we try to schedule patients to receive a set of services. But unlike in a typical outpatient setting where patients would call and make an appointment maybe for a half hour or maybe up to an hour time slot, here patients actually need to receive a portfolio of services. So when we schedule patients to different resources available, we need to consider their needs as well as the resource availability. So it becomes a fairly complex combinatorial and interesting combinatorial optimization problem. And then finally, the last one is in the public health setting. Here we are going up another level. So we started at the patient level to the facility level. Now we are actually at the system level, at the country level, develop decision support tools for the allocation of healthcare workers who recently graduate from medical school and who are going to take on government positions, and how do we make decisions about where these workers should be allocated, considering their qualifications, the demand for different types of workers in different areas, geographic areas in the country, as well as the workers' personal preferences. So that's kind of the portfolio of tools that I'm going to discuss if time permits. But if not, at least you have an idea about what they are, and I'm happy to follow up with you afterwards, either today or feel free to call me if you would like to talk about any of them. So let's start with this one. Okay, I hope my slides will work out fine. So this project was in collaboration with the Centers for Disease Control and Prevention, and I provided a brief history of the project here so that we can appreciate how something begins as a class project. That's how it started, as a class project, and then it became a research project with PhD students. And then once the research and publication phase came to a close, we had to continue the project basically by engaging colleagues from Georgia Tech Research Institute. This is the non-academic arm of Georgia Tech, where we have researchers who actually do work on applied projects. So it basically became a continuity with involvement of different people along the way. And of course, our CDC collaborators have been instrumental in the initiation as well as the current state of the project. So here's the motivation for this project. The American Academy of Pediatrics, along with the CDC and the Committee on Immunization Practices and some other bodies, they published this recommended immunization schedule for children in the United States. So every year the schedule changes a little bit. It may be the number of doses that change. It may be the number of or the types of vaccine included. But we have a schedule that's recommended every year. And if most children in the United States follow this recommended schedule properly, I would just skip to the next talk, and we wouldn't have this part of the talk or this project. But it turns out about 50% of the children do not follow the recommended schedule. So I'll come back to the statistics in a minute. Similar schedules exist in other countries. I know you can't read this, but this is a recommended schedule from Canada. In the United States, the same schedule is recommended for healthy children, regardless of where they live in the United States. In Canada, depending on the province where you live, your recommended schedule might be a little bit different. And they decide on this based on the prevalence of the disease, the demographics, and other factors in the region. So they have different recommendations, which means that if you move from one province to another in Canada, you may actually be behind schedule, even though you may have been perfectly fine previously based on where you live. So we have some prototypes for Canada. They have not been implemented yet, but I just want to put it up there that this is, a problem that we face in other countries as well. So as I mentioned before, more than 50% of the children do not receive all of their recommended doses by age 2, so they fall behind the recommended schedule. And only very few percentage of the children recommended all of the doses at their recommended ages, so they may be receiving too early, too late. And when this happens, the vaccines do not provide the kind of coverage that they are supposed to. So from a health perspective, both individual and public health perspective, this is not desirable. So when a patient comes to the office and they are behind with their vaccination, the healthcare provider needs to construct a catch-up schedule for that patient, considering their age, vaccination history, and so on. And they did a study where they graded physicians on their ability to construct these schedules. They were graded on a scale of 1 to 6, 6 being the best grade they could receive and 1 being the worst grade that they could receive. Basically giving them example cases that are frequently seen in practice, that the physicians or nurses frequently see in practice. And the average grade they received was 2.5. So they weren't creating these schedules in a correct way. And doctors are smart people, they are very knowledgeable, so this is not anything, against them. It's just difficult to create these schedules in a short amount of time, just using our, brain abilities. So some of the reasons for untimely vaccination, parents may forget, they may have the wrong information about the vaccination. As we discussed, these incomplete or incorrect schedules created by the physicians, which may actually make the situation worse. And here are some of the rules on this table. Again, I don't expect you to see this, but just for you to appreciate some of the complexity about the rules that a physician or a nurse or a healthcare practitioner needs to follow when they are creating a catch-up schedule for a person. So there are a lot of rules. The table gives a high-level summary of these rules, and then additional rules are captured in this red book, which is considered the main source for vaccination-related information, and it's updated every 3 years. So it's a fairly complicated problem. We may also have issues with missed opportunities, so sometimes a patient may show up in the clinic. Maybe they don't absolutely need the vaccination at the time, but it may actually be feasible, clinically feasible and okay, to give them certain vaccines while they are there. And you may want to do this, especially if this person is coming from a certain demographic where you anticipate that you may not see them again anytime soon. So if that is the case, you may actually want to be proactive in vaccinating them if it is feasible, clinically feasible and okay to do so. So for adults, how many of you know that you need vaccinations as adults? And you are up to date? Okay, so some of you at least. So we need vaccinations, it doesn't end with childhood. We also need vaccinations beyond childhood. So unlike children where they have the same recommended schedule for everybody, for adults the recommendations actually change. So depending on your lifestyle, work environment, medical history, you may get different recommendations. So here is one set of recommendations for a, say, average person, and then the recommendations may look different, say, for a person who works in healthcare. So the problem gets even more complicated. So I'm not going to discuss the adult scheduling too much, but the complexity is similar, maybe a little bit more compared to the childhood scheduling. So the statistics for adults look even worse than children, so we have more of an issue with catch-up scheduling for adult vaccinations. So our goal in this project was basically to develop an easy-to-use tool to automate this process of catch-up scheduling. So to eliminate the error, to speed up the process, and then overall, along with the tool, also provide information about vaccination. So hopefully, in the long run, this may help us improve our vaccination rates and the missed opportunities that I mentioned. If we are proactively using this tool, we may be able to eliminate some of those missed opportunities and turn them into positive action. And also overall may help us to improve awareness and participation. So from an optimization perspective, I'll put it into an optimization framework now. So our goal is to create a schedule by taking as input the past vaccination history. We look at the remaining doses and we want to maximize the number of these remaining doses that we can feasibly administer. And while we do this, we have a number of requirements in terms of our constraints. So I listed a few of them here. We have minimum and maximum age requirements. We have some interesting gap requirements between different doses of vaccines, not necessarily successive doses. We have constraints about how we can administer live virus vaccine and so on. And then we may also have contraindications, so depending on the timing of the history, sometimes you may have to stop a vaccination sequence. You may not actually be able to continue it to its end. So even if 4 doses might be required, you may end up stopping it at 2 doses. So to the extent possible, we want to avoid these kinds of situations when we create a schedule. So we also have some discretionary measures. These are optional, but could be preferred. For each of these doses of the vaccine, we have an ideal time window during which the dose should be administered. And again, remember, these time windows might depend on the timing of the previous doses. And then we also have an acceptable time window. So this is feasible, this is ideal. So what we see in the recommended schedule is the ideal time window. So ideally we would like everybody to take their vaccines during that time window, but in case of missed opportunities or catch-up, we may also go to this feasible time window, which may be a little bit broader than our ideal time window. So you may choose to administer when recommended, staying close to this ideal time window, or you may want to administer as soon as feasibly possible. So basically you could create an accelerated schedule is what you say. So these are some of the discretionary measures that the physician might use. So some of you who work in scheduling might already see similarities between this problem and some of the other problems that we see in the scheduling literature. So there are indeed some similarities. There are also some differences. We can show the problems example hard even when we look at some of the special cases of the problem. So in terms of the overall structure, we have 2 types of input that go into the decision support tool. The vaccination history and age, that's the input that's provided by the day-to-day user like you and me, or a physician or a nurse. And then the vaccine model language is the expert input that's provided, that actually specifies all of these different rules about the vaccines and how they should be administered. So that input is entered right now about once a year. We make the necessary changes as needed to some of the algorithms also, and then updated as the new vaccine recommendations come up. So we have the algorithm to construct the schedule, and then we have the output. Okay, so this is a real tool. This is the one that's been implemented, so you can actually go and check it online, https://vaxscheduler.org. So as I mentioned, you enter your information. You could actually save, if you are using this tool regularly, you could save your information locally. We don't save anything for you, but you could save it locally and you can upload it, so you don't have to repeat it every time you use it. Or you could enter it from scratch. You enter the birth date and then you enter the vaccination history. And when you are entering your vaccination history, if we see something that doesn't look right, we actually give you a warning saying that this doesn't look feasible. Are you sure that this is the case? And it is possible that in the past you received some vaccines at the wrong time. So we give you the option to enter it that way, but we'll actually check for feasibility and give you a warning while you are even entering the input. And then you choose your option, whether you want a routine schedule, staying close to the ideal window, or whether you want an accelerated schedule to speed things up. So you have that option as well. So this is a screenshot from the adult scheduler. It looks a little bit more complicated because we also ask you some questions to better understand your work environment, history, lifestyle, and so on. As I mentioned, the way you answer these questions is going to impact what kind of output you are going to receive in terms of your schedule. So this is a high-level snapshot of how the rules, the input about the rules look like in the back end. That we specify, again, all of these criteria that I discussed before about the gaps and so on. Okay. So the solution approach that we tried for this initially was an integer programming approach. And we tried different formulations. We tried cuts, form starts, and all of the usual tricks that you will do with integer programming. And we were not able to get good solutions consistently within seconds, which was the goal, right? So you have someone, they push a button and they want to see a solution. They are not going to wait for an hour to come back and get a result. So that path, even though we tried, didn't go very well. And then we realized that the problem has this kind of sequential characteristic in the way you create these schedules. You already start with a partial schedule, and then you really need to extend that partial schedule. So we thought it actually fits very nicely into a dynamic programming framework. So start with the partial schedule, and then you extend that schedule by eliminating anything that doesn't look promising along the way. So you don't have to actually enumerate everything. So to make this dynamic programming approach efficient, we were able to show certain characteristics about the schedules. So for example, we showed some dominance criteria saying that there are these called critical doses which impact, the way we schedule these doses, it's going to impact how we might or might not be able to schedule some of these future doses. Remember, for example, the contraindications that I mentioned to you. Depending on how we schedule certain doses, we might end up with more contraindications, which means we are going to miss certain future doses and we won't be able to schedule them. So the way we schedule the critical doses might impact what we can do in the future, and that way we were able to show some dominance criteria and say, if I have two schedules and I compare them, any completion of this is not going to be better than the best completion of this one. So that actually allowed us to eliminate some of the partial schedule along the way and made the algorithm quite efficient. So we actually have, this has been used, I'll show some statistic later, and pretty much within a second or two you get the solution using this approach. So this is one example output from a 4-month-old child. They received 1 dose of Hep B at birth, and then a couple additional doses of additional vaccines at 2 months of age. So the output that you see is very similar to the recommended schedule structure that the CDC publishes. So as a parent or as a physician, if you look at this output versus the original one, it's very easy to follow, what's going on here. So we have in the blue, we have our doses that are administered. This is the input that the user provided to the system. The yellow ones are the on-time doses. So the yellow parts basically look exactly the same as the recommended schedule because you are already caught up by that time. And then the red ones are the catch-up doses. So you were behind, but we are going to catch you up if you follow this particular schedule. So this was created choosing the routine option that you want to get the vaccines at the ideal time. So you could take the exact same input and create an accelerated schedule. So in this case, some of the doses are going to be pushed earlier. Again, remember, we are not violating any feasibility constraints. We are just getting outside of the ideal bound, but some of the doses now we can actually administer earlier. So you see in green the preemptive doses that come earlier in time. So here's an example from an adult scheduler. We have a 35-year-old female. They receive 1 dose of measles, mumps, rubella, 3 doses of TD, and they remember the date of their last dose of TD, which sometimes we don't remember, especially if there are multiple years in between. So they get a particular schedule. So now let's look at an example that looks very similar. I'm going to change only 1 or 2 little things, and you'll see how the output changes. So same thing pretty much. But now they do not remember the last dose of TD, and they work in healthcare. And you may have visually seen how the schedule changed. So we don't have TD administered anymore. Instead of we have Tdap. In the previous schedule, we didn't have Tdap because they didn't work in healthcare. They didn't need it. And then we have some other things here that they need because they work in healthcare. Whereas here, in the previous case, we had only 1 catch-up dose. Here we have several. Okay, so this is just to give you a flavor of depending on, again, with the adult schedule on your work environment and so on, how the requirements or recommendations for you might look different. Okay, so here's a quick summary on the implementation of this work. So the original prototype versions of this were developed as downloadable, and they were developed by us, with the students and postdocs in the academic side, and they were on the CDC's website for some time, and they were downloaded and got a lot of interest. And then we kept receiving feedback from the user saying, this downloadable version is not working for me. I cannot download anything to my computer in the clinic. Can we create an online version? So at that point we said, okay, so this is no longer an academic exercise, so we need to engage with some experts who are, who are good in software development. So that's when we started collaborating with our folks at the Georgia Tech Research Institute in developing the online version, which is the one that's in use right now. So all together, combined online version and the downloadable version, we had over 1 million users for this. And the distribution is about 50-50 between physicians and families. So parents use this quite a bit as well, and it's also used in the healthcare environment. So it also saw some interest from the popular press, and we've been really grateful to our colleagues at the CDC and also the American Academy of Pediatrics for guiding us in the process and also helping us disseminate the information about the tool. So I'm going to stop here. You have been very quiet, or I've been talking too much, or a combination. So just ask if anybody has any questions on this one before we move forward.
Have you gotten any feedback from people that this conflicts with what the insurance company is willing to pay for?
So not so much that, but sometimes we get the following question. So especially if a child is behind, suppose it's an adopted child, age 1, and they have no vaccination history, or they immigrate from another country. So in those cases, you may actually end up creating a catch-up schedule that puts 8 vaccines on the same day. And some parents, the physicians have no concern. They think it's perfectly fine. But some parents might be concerned, even though some of these come in combinations, so it doesn't mean you get 8 injections, but some of these come in combinations, but still they think, well, maybe it's too much and should we space this out. So from an insurance perspective, if you have a copay for every visit, that's actually a good thing because you get all 8 at once. But from a compassionate parent perspective, it may not be. So the tool gives you, or the physician, the flexibility. They could actually basically limit what they give that day, and then they could create a catch-up schedule given that particular history. And when we discuss this with physicians, we like optimization and algorithms. We say, we could basically optimize this for you. If you want to do only 6 vaccines today, we could try to figure out what is the best 6 to do today, and then before later. But in our pilot studies with the physicians, they did not want us to do that. They said that they would like the flexibility to decide with the patient and what they may have available in their inventory and so on. So we basically leave that flexible. But that's a very good question. So from an algorithmic perspective, it wouldn't be difficult to spread things out or combine things together. But right now, it's basically up to the physician. So we'll move on to our next topic. Oops. Okay, let's see if this one cooperates with me. So this is again a collaborative work with the CDC. You see a pattern emerging here, all these joint projects with the CDC. And I'll explain the team just in a minute. So the motivation for this project came from this growing gap between demand and supply in organ transplants. The orange line you see at the top is the number of patients who are waiting for an organ, and then the blue and green lines are basically the number of transplants and the donor organs available. So you can see that we have pretty much flat line in terms of our supply, and our demand has been growing. So the gap between demand and supply, unfortunately, has been growing in terms of organ transplant needs. So, and we have, unfortunately, several patients who die while they're on the wait list. I show some of the statistics for kidney and liver here. So with kidney, thanks to dialysis, patients can stay on the wait list longer compared to liver, but we still see a lot of patients unfortunately dying while they're on the wait list waiting for a kidney transplant. So the initial motivation for this project came from the CDC with the following idea. They have seen transplant of certain infectious organs in the past. So first of all, they wanted to make sure that this doesn't happen. If an organ is infectious and dangerous for the patient, to the extent possible, they shouldn't be transplanted. But on the other hand, we also have a lot of organs that are considered increased risk, not necessarily confirmed to be infectious, but just considered increased risk. And a lot of those organs end up being discarded because there is this perception that it may be dangerous to transplant them, and there isn't really an easy quantitative way of measuring what the pros and cons are, staying on the wait list versus receiving one of these organs. And then, as I mentioned, we have people who die while they're on the wait list. So the question was, can we find better ways of identifying, number one, if there are these organs which are infectious, can we find better ways to identify them so that we don't transplant them? And also, if there are these organs which are increased risk, can we develop quantitative models so that we can assess the risk and decide when it may actually be a reasonable risk to take to transplant one of these organs versus keeping the patient on the wait list. So that was kind of the initial motivation for the project, and we started the project initially on infectious encephalitis. This was one of the diseases that has been transmitted through organ transplant, and an undergraduate student team worked on this project, so that's why you see this kind of large team. So they finished the project. This was part of their senior design. They graduated, and then we received 2 grants from Carlos Foundation and the Laura and John Arnold Foundation to continue the work in a research context. So we invited some other faculty members and PhD students to join the team. So now we have a nice team continuing the work. And then we also received some funding from some of the Georgia Tech alums who supported the project through their endowment. Okay, so big picture. We have an increased risk donor organ available for transplant, and at that point the physician and the patient need to make a decision. If they decline the organ, then they are going to stay in the wait list. So we need to have a good idea about the wait list survival probability if they stay on the wait list. And then here you need to think about, the longer you stay on the wait list, your condition deteriorates over time. So you may get an organ, a regular organ, non-IR organ, sometime in the future, and then you can actually think about, or we try to quantify, if you wait for a while and then you get an average organ sometime later, you go through the transplant. So how does your survival curve look like under that scenario? Right? So that's your option number, at least depending on how you number it, let's say one of your options. And your other option is you are offered this increased risk organ today. Do you undergo transplant today or not? And if you do, how do your survival chances look like under that scenario? And I know some of you are familiar with this, but in this context, we try to come up with these survival curves. So this is today, we are at time 0, and we are alive, so our survival probability is 1. And as time goes on, this probability is going to go down. And how it goes down is going to depend on the decision that we make today. So we try to estimate these survival curves. Okay, so in terms of our roadmap, let's start first with this infection risk assessment issue that I discussed earlier. So this is actually relevant even outside of a transplant context. So you have a patient who has, encephalitis, but you don't know if it's infectious or not, and if you could identify whether it is infectious or not, you could actually take certain measures, and in particular, if this person is a donor, you would not transplant that organ. So the historical motivation for this, there have been 13 clusters of infectious transmission via organ transplant, and unlike some other diseases, there is not a simple test to tell us whether encephalitis is infectious or not. There are different pathogens that cause encephalitis, infectious encephalitis, and you may have to do a separate test for each one. Even then, you may not be able to cover everything. And some of these tests take a long time, whereas we have a limited amount of time for transplanting the organ after it becomes available. So by the time you do these tests, it's too late for the organ. So basically, we looked at finding some methods so we can identify whether or not the encephalitis is infectious or not. Thanks to the CDC collaborators, we received some data, both case data of infectious encephalitis caused by these 4 viruses. These are probably covering, I'm not sure, 90+% of the cases. And then we also have some control data in terms of non-infectious encephalitis. So we had the usual challenges when you do data-related work in terms of missing variables and what is the case-to-control ratio and so on. I'm not going to go into too much detail on that, but we applied, for the most part, I would say, standard techniques to deal with some of these issues. So here is, I'm jumping to our decision support tool. It actually looks very simple, even though I know it's not very well visible. But essentially, at the top, we were able to find 12 variables that are good predictors, according to our models, of infectious encephalitis. So we asked questions regarding these variables. And we give the option of unknown to the user, because in some cases they may or may not know exactly how to answer the question, so they have that option to choose unknown. And then we give them a risk estimate along with a confidence interval. So if they can answer all the 12 questions, then their the accuracy, the confidence interval is going to be smaller, the accuracy is going to be better, but it still works even if you cannot answer all of the questions related to the donor. So we actually tested a lot of combinations in terms of the variables, how many of them are known, and so on. And you can see that really, if you go below 3, the accuracy is just not good enough. So we basically say if it's 3 or less that you know, then don't use this tool. Only if it's 4 or more, and ideally you should be kind of in the higher range to get good results. So like in many other predictive models, you choose a cutoff, and depending on which side of the cutoff is, you are labeled as this or that. So in this case, we label you either as infectious or non-infectious. So you can see at the top, depending on how you choose this cutoff, the sensitivity and the specificity, basically the true positives or true negatives that we are able to identify, it varies. Right? So it's again up to the decision maker how they would like to do this trade-off in their choice of the cutoff. Okay, so in terms of the summary results, so as I mentioned, it's applicable to all donors, or actually to anybody really, if you want to use this for treatment purposes as well. And compared to the current practice, this is what we found in terms of current practice in the literature, and we tested it. The current practice is actually not doing very good in identifying infectious encephalitis, only about 16%. So our methods, I put the results with a particular cutoff year, were able to improve significantly over the current practice. And the current practice is again not using any kind of tool. It's just basically based on what the physicians reported in the literature as to how they go about identifying these cases. Okay, so now this particular case, as I mentioned, we don't have a test that tells us yes, infectious, or no, not infectious. We have other diseases very relevant for organ transplant. We do actually have tests. So hepatitis C, B, HIV. So we have tests for these diseases, which are fairly accurate. So in this situation, the question is, suppose we have a donor who tests negative for these diseases, any or all of these diseases, but they exhibit certain risky behavior And if this behavior happened relatively recently, such as yesterday, there is a possibility that it's not going to show up in the test results. So what do we do in that case? The test is negative, but we suspect there may be a chance that they may still be infected given the risky behavior. So again, we go through some statistical models and testing, and part of this was actually done previously by our CDC collaborators, so I'll give them full credit for this portion, and we helped them in fine-tuning a little bit and implement into a decision support tool. So you select these donor behavior characteristics, and then the tool basically tells you what your infection risk is, considering how many days ago you may have engaged in this risky behavior. And what we'll do later is incorporate this into a decision support tool, so what happens if we actually take such an organ and put it into a transplant situation. What I discussed so far was mainly, we didn't even talk about transplant as much, but just, you know, here's a person, a donor, or a regular person, and how do we assess this infection risk. So now the question is, if we take these increased risk organs and put them into a transplant decision situation, how do we make decisions in that case? Okay, so yes, please.
Our audience was infectious encephalitis. So I see there is very so the false. Can I say if I read it correctly, the false negative is very low.
Mm-hmm.
Is that because I procure organs, so I just want to offer that organs, and I really don't want to say this is a bad organ, this organ has increased risk? Is that really the mentality go through physicians?
So the physicians, our understanding based on talking to them is they sometimes tend to be a little bit risk averse. So if they see that there may be an issue with this organ, they may not even tell the patient. So they have the first right to say, no, we don't want to transplant this organ. And if they think this organ would be reasonable to transplant, in that case they would discuss with the patient and say, you know, I think this is a good organ, we should consider accepting this. But the patient might still say no. So, you know, if the patient finds out, I don't know, I'm making this up, the donor has tattoos all over the place and they have engaged in certain types of behavior, even if the physician says the test results are negative, this is a, you know, young, healthy person and the organ is in great shape, the patient might still say no.
So there's a risk perception issue, right? They have a wonderful tool, I think, I'm asking you how in the time, very time sensitive, this is the problem of time sensitive nature. At that critical moment, how much this can be, how likely this can be adopted?
Yeah, so I'll show you a couple of screenshots and then we'll discuss the timing issue. And so again, our understanding is that in the absence of decision tools, the physician might receive a call in midnight. They answer, they hear the information, and they make a call. That's how it is done right now for the most part. So with these tools, the information requirement is not that large. You could literally do it in a minute. And it at least gives you some assessment quantitatively in terms of the trade-offs between different diseases. But I'll show you some screenshots, hopefully it will be clearer.
Another question, how about other factors that may come into the decision making? So this is the risk, yes, I know there is increased risk, and there are many other factors that decide that this is a good match, and if you weigh the risk here versus other factors.
So actually, all the other factors that you would put into a survival curve estimation, we consider all of them along with the risk. So actually, what I'll show you first is what we have done for just regular organs, and then we take the next step and incorporate the increased risk organs into those models. But that's a very good question. Yeah, there are a whole host of factors that affect this survival curve in terms of a match between the patient and the donor.
This is a quick question. So you mentioned that some of the organs that discarded, they consider high risk. Do they ever actually test those organs to see whether they do have those infectious diseases?
So in case of the HIV, HCV, and so on, yes, there are tests. And the test might show negative, but it's considered increased risk. So the way the allocation process works, and again, I apologize if I repeat this information, some of you may already know. So when an organ becomes available, there is depending on the region, usually it's first allocated regionally. So it will go to the patient who is at the top of the list, and that is not a static list, by the way. It will depend also on the organ that's becoming available. And then that person has maybe about an hour to give an answer, then it goes to the next person, and so on. So what we find is that for these increased risk organs, they tend to get rejected more often. They are more likely to the patient saying no. I should say decline, not rejected. Decline, reject is used for something else. Decline, more often. And then sometimes it goes on to the next, to the next, to the next, and then you reach basically the called ischemia time, and that's it.
But at the end, did the organ still go through a test to see whether that high risk, meaning you don't know for sure, right?
If they did a test, they would get the same result because, again, suppose somebody contracted HIV yesterday, it would not show up in the test today, most likely. So they don't necessarily know 100%.
Still don't know.
Right.
Because I just wonder whether your model is able to validate by the truth.
But there are cases of infectious organs being transplanted.
Okay,
so that's how we calibrate our models, basically saying, okay, even in those cases, we can see what the survival curve looks like, and then adjust the curve based on the risk. Yeah, that's a very good question. Yeah.
All organs are affected equally by these diseases. I mean, a liver may have a higher chance to be rejected if you have encephalitis than liver, or?
Yeah, that's a very good question. So, the wait times are not the same, or the chances of survival, depending on what kind of organ you need, it's not the same. And that actually might impact, one patient might say, I really don't want this organ from this donor, and another patient might say, I want it because I'm a different kind of patient and I need a different organ. So I'll give you some charts on that one, but it's a very good question. Okay, so what I'm going to briefly discuss now is the survival curve prediction models that we developed for, I'm going to call them regular organs. These are not necessarily increased risk organs, regular organs. So we received data for recipients who underwent kidney transplant from 1987 to 2014. And so the first thing that we looked at is, should we use all of this data or only the more recent data? Because there's been changes in transplant techniques as well as post-transplant care. And, thankfully, transplants are more likely to be successful today than they were, say, 20 to 30 years ago. So we looked at different cutoffs in terms of timeline, and then we basically decided to use post-2002 data for multiple reasons. Number one, we could see a significant difference, and then also some of the guidelines and evaluations changed just around that time. So we thought that could be kind of a good cutoff, both from a historical knowledge perspective and also based on what we saw statistically. So again, a very quick summary of how we remove certain variables if they're missing observations and so on and so forth, and then how we reduce, for example, some of these variables have multiple values, and we kind of combine them not to end up with too many variables. So we end up with 73 variables going through some of these, again, relatively standard steps in our analysis. So next, we looked at the importance of different variables. If we were to include these variables in our predictive models, how important do they seem based on these important rankings? And we looked this time at the age cohort difference. So we again looked at different breakdowns. If we split our cohort into two age groups, we didn't try more than two age groups at the moment, but that's something that we could try moving forward. And we actually saw differences between 49 and younger and 50 and older. So we took 50 as a cutoff. And in a nutshell, you see differences in terms of the variable importance when you look at these two age groups, perhaps not so surprisingly. And then we selected a subset of these variables. We tried different methods for prediction and selected a subset of these variables to include in our methods. And again, there is a difference in the variables that we actually selected and put into the models depending on age. So what we found is that for older than 50 age group, the well-known Cox proportional hazards model, again, for those of you who are familiar with this literature, this is the model that's been commonly used in the literature for survival curve estimation. That model actually performed quite well. For the 50 and under group, the random forest model performed much better than the other models that we tried. So we basically said, okay, our predictive model is going to be a combination of these two, using the random forest for 50 and younger, and then using the Cox model for older than 50. Visually, here is how the results look like, and I'll show you more quantitative evaluation just in a minute. So this is what we get with our predictive model in the solid line, and then the dashed line is the Kaplan-Meier survival estimate. This is basically based on what we see in the actual data. So visually, you can see our predictions actually look quite good, and then we looked at whether they are consistently good across different quantiles, and the answer is yes. So even if we dice and slice, we still see fairly good predictive accuracy using our proposed model. So where does this fit into the literature? Remember, what I'm discussing so far is not for increased risk organs. This is for just a regular organ. And there has been a lot of other methods proposed in the literature for this kind of survival curve estimate. So these are some of the recent models that have been reported, improving upon previously published models in the literature. And in this world, what you see is you see relatively small changes in the predictive accuracy. So the concordance index is what I'm listing here. It's essentially when you compare a pair, whether your model correctly predicts which of these two patients is going to live longer, essentially. So it's kind of a ranking, accuracy of ranking kind of index. And then the integrated Breyer score measures the error from the between the predicted and the actual. So the recent models, you see that they are in the 6.9 close to 0.7 range, and then here you see if we use the Cox model with our parameterization and choice of variables, we get 0.706. If we use random forest for both cohorts, we do slightly better. If we use the combination, like I said, random forest for younger cohort and the Cox model for the older cohort, we actually are able to get to 0.724, which is significantly better than some of the other models that are published in the literature. Again, I say significantly, the difference looks small, but the progression in terms of predictive accuracy has been really in small increments in the literature. So this gap, even though it may look small to us, it's actually significant considering what we see in the literature. So EPTS for kidney, this is what is currently used in practice. This is what they reported. They didn't report the third digit. So in addition to comparing with this published number, we also used or applied rather the EPTS method on our data just to make sure that we are not getting a data advantage for whatever reason. And the EPTS model on our data performed just slightly better than the published one, but it was quite close. So we were able to validate it that way as well. So in the EPTS model, they look primarily at the patient characteristics and not donor characteristics. So we actually, in our model, we look at the donor characteristic as well. So we are estimating these survival curves for that specific combination of patient and donor. So in a way that gives us better accuracy, but you might say, well, maybe that's a little bit unfair because we are using more information than the EPTS model. So we also used the proposed model without the donor variables, and we were still able to do better than the EPTS model. So it seems like a reasonable model in terms of improving the predictive accuracy, regardless of how you look at it, whether you use only the patient variables or both patient and donor variables. But this would be our proposed or suggested option. If you have that information, you might as well put it to good use looking at the combination. So this was our first step, developing these models for regular organs. And then we also incorporated the increased risk organs into the model. And I'm not going to go into the details, but then embedded them into this decision support tool, which basically collects information about the variables that we include in our model. So we are simply asking what the values are for those variables. And then at the end, this is the kind of output that you are going to see. So here, you can choose, basically you can uncheck all of these, meaning it's a regular organ, just, nothing about high risk. Or you can check some of these so that we can show you how these survival curves would look like in case of a high-risk scenario. So, of course, one option is always to wait. So this is the black one, if you just wait for a non-high-risk organ. Or if you accept an organ which is an increased risk HIV. So again, remember it's testing negative, but the donor has some behavior that's considered risky. And here you see another one for hepatitis B. So here, the decision would really depend on how long you expect to stay on the wait list. So currently, they publish median wait times for a region, but to our knowledge, there isn't anything out there that tells you specifically, given who you are and where you are, how long you might be expected to wait. So that, to our knowledge, is not out there. So actually one sub-team from our group is looking at wait time estimates, so specifically considering patient characteristics and their location. The location makes a huge difference in terms of wait times, and trying to come up with these estimates. But even with just the median wait time estimate and some idea about where you are in the wait list, you might still know whether you are likely to receive an organ within 2 months or within a year, right? So at least at that level, you might have some idea. And if you are not expecting to receive an organ offer, say, for another year, year and a half, or however long it might be, this might still be useful in terms of informing you with your decision at that point. So here, going back to your question, I was showing you a kidney scenario here. So here we have a heart scenario, and you can envision that if you are a patient waiting for a heart transplant, your condition is deteriorating very quickly while you're on the wait list. So here you might actually be much better accepting this increased risk organ, even if your wait time is very short. So we tested these different scenarios via a large number of simulations, and in a nutshell, so here is the summary. For the increased risk HIV or hepatitis B patients, a significant percentage of them would actually be better off accepting an increased risk organ versus staying on the wait list. Sorry, I said patients, I should have said donors. So for hepatitis C, the benefit seems to happen only if you are expecting a long wait time. Only then it looks like accepting an organ which is increased risk for hepatitis C would be a good idea. However, all of the data that we use are prior to the most recent hepatitis C treatments. So now the game has changed, and the results we are showing are very conservative because that was prior to the new advances in treatment. So we think that these numbers actually look a lot better today, although we don't have enough data to test for the current situation, but that's something to keep in mind. So here are some numbers on liver. Again, most of the patients would, the majority of the patients would benefit from receiving an increased risk organ, depending on the days on the wait list. The last thing I want to mention is the allocation model that we are working on, and I don't have any slides on this. I'll just summarize in one or two sentences. So, as I mentioned earlier, with the current allocation, we do mostly one at a time, the offers, or maybe 2 or 3 at a time, provisionally calling this number 2 and number 3 on the list, saying that if number 1 declines, this might be coming your way. So, just start thinking about it. So, another sub-theme of us, we are looking at a more broad allocation scheme. So instead of going to top 2, top 3, how about if we go to top X and tell them this organ could be offered to you, so just consider it, think about it. So the benefit, of course, is expanding this list is if one of them accepts within 1 hour, you could still give it to the person at the top of the list. So you are not in any way violating the current ranking that they are using, but you are increasing the chances that somebody might say yes. On the other hand, you are giving hopes to people, and if you tell them, sorry, you didn't get it, and you keep doing this, that's really not good for patient morale. So you basically need to trade off these two things in terms of increasing organ utilization, reducing wait times, and the potential negative impact on patient morale. So I'm happy to talk about that during our break. I'm going to stop here. And I'll put this back up, my original slide. So good thing I gave you the 1-minute summary on the other two. And again, happy to discuss any of the remaining 3 topics offline with you. Thank you very much for your time and attention.